Hello. Today I'll be talking about principles in initiating medical therapy in glaucoma. What, according to you, do you think is the most important factor in your choice of medication for treating a patient of glaucoma? Well, the new consensus is that preservation of visual field is a new standard of care in glaucoma. It is not dependent on how effective the anti-glaucoma medication is in reducing intraocular pressure, how few side effects there could be, or the cost, or even the flat diurnal curve. So, the more and more emphasis is on better quality of life at a sustainable cost is the aim of glaucoma treatment, which is more and more patient oriented now. The decision to treat a glaucoma patient is very individualized, and various studies have time and again shown that a reduction in intraocular pressure, which is the only modifiable risk factor, is protective against the progression of glaucoma. The challenge is to identify those patients at risk and treat them effectively. Before instituting therapy for a patient of glaucoma, it is important to devise a target intraocular pressure. Target intraocular pressure is dependent on a lot of factors. You need to have a lower target intraocular pressure if the stage at diagnosis is advanced, if you have additional risk factors in patients like family history of glaucoma, the associated eye being blind, high myope, etc. If the untreated IOP is low, you need to have a lower target intraocular pressure. If the rate of progression is fast, again, and if the life expectancy of the patient is long, again, you need to have a lower target intraocular pressure. But before starting therapy, unless and until the patient is very advanced or has a very high intraocular pressure or very severe glaucoma at the time of diagnosis, for a regular patient, always obtain several IOP readings, not done just once a day, but a diurnal variation of intraocular pressure should also be noted. All the medical and ocular history should be taken, and the severity of glaucoma should be graded with the help of visual fields before starting therapy. Now, practically, the clinically applicable target range of IOP, which is generalized but not exclusive, is that for early glaucoma, you need to have a target IOP of about 15 to 17. For moderate glaucoma, we are happy with the target IOP of 12 to 15. And for severe glaucomas, around 10 to 12. And in choosing the appropriate medication, keep into account the efficacy of the anti-glaucoma medication you're using to treat your patient. Also, keep the cost minimum and the dosage minimum so that the compliance improves. The rule of thumb is that 20% reduction is desired for mild cases, 30% for moderate cases, and 40% for severe cases. And always start with monotherapy unless and until your patient has a very advanced glaucoma or very high intraocular pressure at the time of diagnosis. So, a comparative meta analysis of various drugs in our glaucoma armamentarium shows that the prostaglandin analogs have the highest reduction in intraocular pressure, followed by beta blockers, followed by alpha agonists, and then followed by carbonic anhydrase inhibitors. Amongst the PG analogs, bimatoprost is also at the topmost in the amount of IOP reduction it causes. So, your first drug of choice for a newly diagnosed open angle glaucoma, ocular hypertensive, or a primary angle closure disease patient post LPI is usually prostaglandin analog. Why? Because it brings about the maximum reduction in IOP, about 25 to 30%, and has the lowest dosage, which means the frequency of application is just once at night. It lacks relevant systemic side effects, although there are ocular side effects, and non-responders are very few. However, if you do have non-responders, switching within the class of PG analogs, like let's say if a patient is not responding to latanoprost, switching them to bimatoprost may cause a little more benefit than the others. But practically speaking, the difference amongst these drugs within the same class does not differ in its ability to reduce the IOP by more than 1 or 2 millimeters of mercury. And prostaglandin analogs are contraindicated in inflammatory glaucomas. So, if you need about 20% reduction, beta blockers also can be your treatment of choice. However, be wary of all the contraindications and systemic side effects that beta blockers can cause and choose your patients accordingly. Always make your patients aware of the side effects before starting the therapy. But if you need a reduction of more than 40% in intraocular pressure for a patient, combination therapy is the way to go because no single drug can reduce the IOP for more than 40%. But never start with a combination therapy, except, of course, if the patient has a very advanced glaucoma or very high IOP. But always start with monotherapy, and the time interval between the therapeutic incremental steps may be decreased. Combination therapy is also more superior than putting two separate drugs because the adherence is better. The washout effect of earlier medications is not there. You also have reduced exposure to preservatives and the cost comes down. But be mindful that don't use two anti-glaucoma medications, combination medicines, both with timolol each. We have various fixed dose combinations. We almost have all the drugs combined with timolol as a fixed dose combination. We also have timolol free therapies, which are combinations of brinzolamide and brimonidine. And we have a combination of three anti-glaucoma medications, which is brinzolamide, brimonidine, and timolol as well. So when to switch, when to add. So when you have started with your first choice monotherapy, and the patient is tolerating it well, it is effective on reducing the intraocular pressure, but your target IOP is not reached. So it has brought down some amount of IOP, but the target IOP is not reached. In these cases, you add a second drop to reach your target pressure. But if the monotherapy does not bring about the amount of IOP drop that you desire or you expect from that particular class of anti-glaucoma medication, you switch the monotherapy to something else. And always make sure not to give too confusing regimens to your patient because adherence reduces with confusing regimens. So even if there is progression in only one eye, you may give the same medication in both the eyes just for the ease of patient understanding. Then there are also newer anti-glaucoma medications in the market, like the Rho kinase inhibitors that we have in India are nitarsodil and ripasodil. These are said to be having equal efficacy as prostaglandin analogs, more or less comparable. However, major limitation of the use of these medications is because of 60% cases of conjunctival hyperemia. It can also cause cornea varicillata in 12% patients and also subconjunctival hemorrhage in 15% patients. These are preferred drugs for primary open angle glaucomas and ocular hypertensives. They have multiple mechanisms of action because of which they are known to cause a significant amount of IOP drop, and they are good as adjuncts to the existing class of anti-glaucoma medications for the reason that it has various mechanisms of action. Then we also have the latanoprostene Bunod, Vyzulta, which also has similar efficacy as nitarsodil when used as an adjunctive therapy, bringing about 2 to 3 millimeters of mercury further IOP reduction. This also has a dual mechanism of action. However, the safety of these two new anti-glaucoma medications has not been proven in pregnant and lactating women as well as in children. And both these drops can be used as once a daily dosing at bedtime. Thank you, and I'm happy that we're all getting together in World Glaucoma Week 2025.